Thank you so much. It is my pleasure to be here with this esteemed panel today. And thank you so much, Angela, for that really informative overview on where we're at today. I think you brought up some of the really key things that have contributed over time: the ultra processed food, our move to corn subsidy, the high fructose corn syrup, the additives. I want to ask the group, if we're looking back outside of that, outside of COVID, what are some of the other reasons that might explain why the rise of obesity continues to climb, despite our efforts of knowing this and really our efforts to curb it? So we're more health conscious globally. So just real quick, if you have thoughts on why this continues to rise.
Well, let me start. I mean, clearly all those things are important, but we've also designed our lifestyles quite differently. We're a lot less physically active than we used to be. We sit more, we walk less, we drive more. Things in which we used to do as a routine. You know, people would get up and go to the grocery store. They would walk and they would walk back. Kids would walk to school and they'd walk back, or they'd ride their bike to school. We now put them on a bus. They do walk, but they only walk about a half a block to get to the bus stop. And then they ride to school, and then they walk the 100 yards to go into the school building. We've taken recess out of school for children. So we've designed an environment which makes us much more sedentary, and we have just watch our body weight grow. Look, I'm not a small guy either, and I can tell you that over time we've all gotten worse, and this staying at home for the last year and a half has made it much worse.
If I can add to that, and I couldn't agree more with Dr. Benjamin. And I think one of the challenges is we really do lack the tools to actually understand the environmental impacts, the real world environmental impacts. I think we've made tremendous progress with some of the clinical research and the behavioral research in this area, but I think we still lack a lot of that knowledge of what is that daily routine environmental impact, what are those real world barriers that are really contributing to all of the components that makes each individual person's disease rather unique.
And I'll add to it as well, and I agree both with Dr. Benjamin and Dr. Grove, as well as Dr. Fitch from earlier in that excellent presentation. There are a couple of elements that we're also seeing that we think are driving it beyond the sedentary lifestyle. Some of it is the increased use of drugs for chronic diseases and not knowing that some of those agents actually have an obesogenic capability. Another issue is that we're seeing a similar increase in mental health issues. And it's those things that get unrecognized that play a big part in it. We are also seeing that this is another area in which the lack of health equity is raising its head. You watch the different distributions of obesity across different segments of the population. But the biggest thing I think it is that people aren't respecting this as a disease. Just like Dr. Fitch said, this has become somewhat of the stigmata that's associated with obesity. And the perceptions, not only by society, but also by the treating community, that this is somebody's will, or lack of it, that gets there. And when you put together all of those things, the absence of a recognition that this is a multidisciplinary disease, the stigmata that comes across, and stops individuals from seeking appropriate treatment, that only leads them to get further weighed down by the mental stress that they have and continue to experience an even greater problem over time. And then finally, the absence of a respect for the social determinants that interfere with life circumstances that make it challenging for anybody, but particularly for people who struggle with access of finance, etc.
Just to add a quirk in there, and this comes from what Dr. Fitch had said in her talk as well. I mean, when you think of other chronic diseases, the idea that you'd go into your doctor's office, your healthcare provider's office, and them not take your disease seriously. If you were a cancer patient or you had lung cancer from smoking, there would still be empathy for that patient. We don't wait for individuals to have a stroke before we start treating blood pressure. That understanding, even by our healthcare providers, is still something that is very concerning to me.
It sure is. And I think just knowing that we need to shift this paradigm to that this is a disease is really the key that we keep coming back to. But beyond that, what paradigm shifts need to happen in order for us to reverse this trend from keeping to go up and up and up?
Yeah, I think the most important clinical one is that we need to move this into an environment where clinicians recognize that their only therapeutic option for their patients is a consult to the dietitian. That is always certainly important, but it is not necessarily, quite clearly not the only option. And it rarely results in a really full assessment of the patient's needs, their psychological needs, their emotional needs, their physiological needs. You know, let's draw some blood for TSH, for thyroid disease, and let's send you to a dietitian. And then when the TSA comes back normal, and they may or may not get to the dietitian, the therapeutic intervention, quite frankly, often ends until that person ends up with type 2 diabetes, and then the race is on to try to address their type 2 diabetes. And then it becomes basically a spiraling down clinical engagement where you're now treating their diabetes and then their heart disease, and then tragically, you know, their amputation from their diabetes. So I mean, it doesn't start early enough in age to start with, and then it doesn't continue. And again, not even doing it in a multidisciplinary way. I mean, a dietitian is very, very important, but this needs to be a disease that looks like and address it for the syndemic that it is. Not just that it's not just a physical finding that people have.
I think access, as was already pointed out by Dr. McGlory, I mean, I think is real key, not only for just our vulnerable patient populations, the ones with, you know, social economic barriers to it, but even in the remote parts of the country. I come from an agricultural community, and many of my family members don't have ready access to healthcare, and it's certainly not specialists. And so I think if anything comes out of benefits from this COVID experience is going to hopefully be the telemedicine that will provide greater access. And there's no reason for telemedicine not to progress to an easier access for those with financial barriers too. So I'm hoping that there's some benefit, because in treating this chronic disease, what is clear, and you could argue that from Verda's experience, it's that strong, continuous, sustained engagement with the patient over time. Doesn't matter if it's pharmacotherapy or lifestyle management, it requires that regular reinforcement for a sustained period. We know that individuals can have success in the short term, but if we want to sustain that weight loss over long periods of time, it requires access and continued engagement, in my mind.
Dr. Migliore, you might be on mute.
I should learn to speak sooner, maybe come off mute, because all the good points are already taken up by the other panelists. But a couple of things that I think deserve mention is, number one, that the education on what this disease is and the disease model needs to be better trained, and it's across the system. Really to get an understanding of all the interwoven parts here and get a real appreciation that this is a chronic and relapsing disease. The second thing is cultural competence. that I think needs to be made aware of, given the diversity of our world and the way in which people learn and the way in which we engage people really requires us to do a better job of being able to relate to everyone we treat. And then the final piece is to really try to destigmatize. And one of the best ways to do it is even to start with how we refer to people. We've got to start using person first nomenclature. This is an morbidly obese individual. This is an individual who is afflicted by obesity. And we got to treat it that way. We don't refer to someone by the nature of their prostate cancer. We really got to start being more respectful of these people who are really, and through no fault of their own, are subject to this disease that needs to be appreciated as such.
Great. I really like this question. I want to know what you think which latest advancements in obesity research are you most excited about? So this could be scientific, policy, behavioral, anything. And how close are we to really being able to implement this with our patients and our clinicians?
Maybe I can start this time. I think there's just amazing research across the board. And of course, that's the basic research is still near and dear to my heart. And I am continually just blown away by the new technologies for mapping brain circuits in the regulation of food intake. But I must say that the areas that I'm most excited about are really some of the new computational tools, the AI machine learning tools that are allowing us to move beyond this analysis of individual data sets to more of the comprehensive multi-omic integrated data analysis. I think this area really is providing some amazing insight into transcriptional networks and protein networks and even crosstalk between different organs and cells that allow us to better understand the disease, but even more importantly is probably better understand what is healthy, to be honest, because we don't even have a strong understanding of what is healthy and what is a pre-disease state person or who's early in the disease state. And I think this will really provide us with a much greater tools in the future to actually not only diagnose and treat the disease early in progression, but even get into the preventative health and precision medicines. But one of the things we are still really lacking, I think, are the technologies to integrate behavior into this, real world behavior. Because I would really like to see us progress to where we have this interaction between behavior and biology in the real world, and that can help with the probabilistic risk analysis of diseases of each individuals, and again, get us into where we can start progressing with precision medicine and preventative health, which for this disease in particular, I think is going to be critical.
I think Dr. Grove is being modest. One of the things I think that's most encouraging has been the semaglutide introduction. And, as you start, looking at that, you finally got a drug that looks very reliably. You start seeing, 90% of people losing 5% of their weight with its treatment. You get impressed. It's still early. It was just approved in April. But, that you got a drug that works, in real world terms. You want to make sure that it continues to be used after it's been introduced. But you need to really be able to gain confidence that this is a path and to have something like that. But I think, bariatrics, I'm a surgeon, so I'm going to raise that. But bariatric surgery is also effective. However, it is not effective if you don't bring the other components to it. The most effective bariatric centers in the nation isn't just because of what happens in their operating rooms. It's because of all of the other multidisciplinary approaches to which they take to it. And if you ignore those, people will find a way to put on weight, despite the fact that they may have a very small pouch.
And we have a lot of science that's sitting on the shelf that has just not been, adopted. And I think one of the challenges we have in medicine is that we study a lot, we learn a lot, and it sits on the shelf for many, many years before it actually gets moved into common practice. And just to add one research concept that I don't think really has been fully explored, and that is a better understanding the difference between obesity and fitness.
Yeah.
Think about the number of football players and other athletes that we have who are physiologically obese, and yet they dunk with the best of them. You would not want to line up against them in a football game. They can run pretty well, and yet metabolically, they have the same cardiovascular risk and the same diabetes risk that someone who is also the same body habitus, the body weight, but not as cardiovascularly fit. And I think we need to better understand that that paradigm as well as part of this process.
To add to that, I mean, I was maybe wasn't as clear when I talk about it. I mean, I think we still lack that understanding between what is healthy and what is the disease state, and BMI is not the defining factor there for that, and it can be so misleading if that's all the information that we have to diagnose a patient. And I think that's why the tools for the real world analysis and investigation are going to be key. And I will make a plug here. I know NIDDK recently launched a partnership. It's called Accelerated Medicines Partnerships, Common Metabolic Disease. And this is a collaborative effort between all of the NIDDK scientists and some pharma industry, Pfizer, Amgen, Lilly, and Novo Nordisk. And it's these types of partnerships that will provide, hopefully, the future data that will help us better understand this disease and the healthy state.
So we just brought up the new semaglutide, their GLPs that are being used, and we know that the use is going to increase. They're really great drugs. How do you think payers, we have a lot of employers and payers on the line, how do you think about the economics of addressing obesity? How should they think about that? What's the value? How does the cost compare to the benefits?
I'll start off, given that this is where I'm coming from. This gets treated like every other introduction of new capabilities from life sciences, which is first get an understanding of what happens to the whole person when this is introduced for the problem as compared to what other things. We know the very impressive weight loss results that there, and also the improvements that you see in cardiac risk factor, metabolic risk factors and the like. My training was a liver transplant surgeon, and one of the things that we know, and that's why I was really intrigued by Kevin's title, is that this really is, we're going to be facing an epidemic of non-alcoholic fatty liver disease, which leads to cirrhosis, which leads to me getting a job again. And that's the kind of thing that you look at in the long term. It seems intuitive, but we shouldn't be relying upon intuition. Let's get some proof about what's there. These studies were well-designed studies to prove the value of the drugs, but they go up for 68 weeks. It's really a longer horizon. How would we evaluate it? Very simply, you don't mind spending more on a drug if what you see in the future is a better outcome, and the better outcome is proven because the total burden of disease is reduced. You do that, it becomes the cheapest form of medicine around. And that's the way in which we look at things. Look at people with the problem, and then look at the horizon. The endpoint can't be the immediate, and it shouldn't be just the immediate endpoint. That's a very important one. But the long-term endpoint, what happens to disease in these individuals over time? And whether it's a defibrillator, whether it is a medication for coronary artery disease, or whether it's to manage obesity, you still use that lens. Our contractual commitments to our clients are that we will provide them with anything that improves outcomes, outcomes being both clinical as well as economic. You wouldn't look for an economic return in the absence of an improvement in clinical outcomes. But if you have a clinical outcome which is as good as that exists or better, then you make that the basis of your economic consideration. But clinical outcome always trumps economics.
But I think one of the challenges here is this is a chronic disease, and that's I know that in discussions that I've had is always that battle of is was pointed out, the short-term gains versus the long-term gains when you're dealing with a disease that you're going to battle for your entire life. I myself, I would argue I'm considered well-educated in this area. I'm a world expert, but I still myself struggle with this disease and the management over my entire life. But then I even take a step back and look at childhood obesity, and that the health implications and the cost implications of that are mind-boggling and quite devastating in the long run. And if we can't figure out a way to provide that access and treatment early on and to young people, the economics of this is going to blow up to where nobody can afford it. So.
Right.
So I'm going to remind all those dialed in, if you want to just input your questions into the chat, we're going to get to them in a second. I think this next question, we've already started to get some questions come in from the group, but really, how do you address these underlying behavioral factors that contribute to obesity without exacerbating the stigma of the condition? So there's a commentary here. Many obese people feel their providers ridicule or judge them for not losing weight. How do we change this attitude and stop fat shaming people?
We clearly have to start early in medical school. We have to teach patients in medical school and nursing school, those in PA, anyone who's taking care of patients in a clinical environment, that how to treat this disease. And I can tell you, when I went to medical school, I didn't have a lot of training in how to manage obesity. I had lots of classes in managing diabetes, hypertension, great orthopedic rotation about amputations, a wonderful ophthalmology rotation about how to handle intraocular eye disease from people with diabetes. But obesity, not a bit. In fact, I didn't even get taught how to write a consult for diabetes. Now, we did have a nutrition course, and we did talk about adequate nutrition for individuals. But it wasn't until I really got into public health that someone pointed out to me that most likely the person that's sitting in front of you is not the person who prepares the meals for that family. And so that my consultation, and I started off as an internist, I ended up in emergency medicine. But when I was practicing internal medicine, I can tell you that it never crossed my mind that the person I needed to really be sitting down and talking to was the person who was actually preparing the meals for that family, and not the patient that was sitting in front of me.
Yeah, I think family health is so pivotal to this. And my background was more in women's health prior to joining Novo Nordisk, in pregnancy and health and nutrition during pregnancy. And we talked to a lot of the women that were living with the disease and were so concerned about being pregnant during that time. And so they're obviously very motivated to do something, but the family structure was a barrier for them. If the husband was not on board with changing the diet and the health paradigms, then it really broke down. And obviously the children needed to be motivated. And I think in the future, we really need to find a way to engage the whole family in these types of structures to provide family health and not just individual health. Dr.
Migliori, you're on mute.
You'd think after 20 months of this, I'd learn. I'm going to add to what both my colleagues have said it because I absolutely agree with them. When you start looking at this is really has to change the mindset. It really has to start with people feel safe in talking to a clinician. Earlier, we mentioned telemedicine. To get to the behavioral issues, one of the things that we've noticed in our behavioral medicine businesses is that before the pandemic, we had approximately 5% of our visits done, through telemedicine. It went over 65% during the heat of the pandemic. But you know what? After things started cooling off, people preferred it. And the reason was they didn't think anybody would see their car in front of the psychiatrist's office. And it became a means for them to have better compliance in better ways. It's one of the technologies that's there. But it really people have to feel confident that you're respecting them and you're treating this just as if you were treating them for coronary or renal risk factors. And to start that way, and it really changes a change in mindset for those of us who provide care.
Can I challenge my panelists as well, or ask the question, not so much challenge? I mean, is having available tools for the physicians, for the healthcare provider, is that the key component to allow that conversation to happen?
I'll give my 2 cents on this. We have about 57,000 primary care physicians in the company now delivering care. They constantly look for tools. These individuals who at one time people would think that they were technologically challenged because they didn't like the electronic medical record systems have become our leading force for having us explore ways of using tools in the office to simplify their work and to cover broader populations. We're changing the way in which we're paying people to value-based payment systems. That causes them to start thinking of ways in which they can help their patients without having them come to the office. So all of these tools and gathering all of these insights, particularly when we start looking at what you and the life sciences industry are going to continue to bring to the table in terms of new findings and new relevance that can really change the trajectory of disease. They're going to be looking to keep up with their knowledge base just like they're trying to keep up with their patient base.
Physicians love tools. We always say that we want physicians to be independent thinkers and to get out there and be independent in our thought. And every single one of us carried the Washington Manual in our pocket, or when we're doing surgery, the surgical equivalent of that in our pocket, because we needed that brain. Physicians actually do love tools. We may not call them tools, but there is so much information that's flying out today. The amount of journals and new science that gets reported and then taken back and then corrected and then advanced. We need someone to help pull this together so that when we go in to see a patient, we certainly have the basic training to have an intellectual thought about what to do. But the more we can have something to help us think through that process and have the place to go, the people to contact, the supports that we need at a moment's notice when we have the patient, I think you can't go wrong in doing that. And I'm also an advocate for telemedicine because I think the more that we can engage our patients and cut down their transit time, a lot of managing some of these chronic conditions is simply touch base with the patient more and more for shorter visits, more and more, just to keep them motivated, keep them engaged, and to correct things that aren't being done right.
Well, I would point out that some of our big technology companies have amazing tools to understand consumer behavior, consumer engagement, and consumer experience. And I sure hope we can learn from that and apply that to patient engagement and patient experience.
The other thing about these tools that allows a doc to keep better track of progress, This is a chronic and relapsing disease, and to be able to have a dashboard that allows you to look at each individual patient as well as their practice patterns is helpful. One thing that our physicians that I mentioned earlier has taught us is, listen, I need tools for two things. Number one is to show me what protocols are available. And number two, tell me more about that patient in front of me that I would otherwise not have access to. You give a physician both of those things, then we'll be paying the physicians to do what they do best, which is making the ultimate decision. It's going to be a far better informed decision, but ultimately the talented physician is the one that can make the decision with that knowledge.
So I'm going to just give us a little time check here. We have just a few minutes left and a ton of questions. And I'm getting a lot of questions about processed food and thoughts on responsibility of food companies and government in producing these processed foods and how to get access to food deserts. So thoughts around just that whole concept of the diet component here?
Let me start with the food desert piece of this. People think of food deserts as a community where there's nothing to eat in that community, and that's not true. There's lots of stuff that you can consume. It just happens to be high salt, high caloric, high fat foods. When you've been working 2 shifts and you want to get something to eat, and they're really the only place where you can go in the community is some place where you can get soda in the front row, potato chips in the second row, and other things. And of course, those stores make their margin on selling both alcohol and tobacco. That's a problem. And we've got to figure out a better economic model so that we can put smaller stores in those communities where people can get nutritious foods that are fresh at an affordable price. That's the first thing. Secondly, you've got to make sure that we provide, quite frankly, a living wage for people so they can afford to get those foods. And then we need to make their communities walkable, bikeable, and green so they can get up, and they are going to be less physically active. Remember, these are folks in many cases are working 2 shifts. They're not physically inactive. They're actually very, very active. They're catching the bus, many of them are not driving, but it's being offset by their diet. And that diet, drives that, because what they're eating are just the foods that are processed, that have, lots of corn syrup in it, because that's what's available to them.
One thing I've always been intrigued with, and we watched it during the pandemic, was how well prepared food supply chains can operate. And Grubhub and all of those. We start thinking about if we could mitigate the social imbalance created by this notion of food deserts. Perhaps that can help mitigate the health disparities that we see and to try to achieve health equity. But that kind of thing where perhaps even to make it simpler, going back to Dr. Fitch's comments about food replacements, to provide a structured, healthy meal. Perhaps, and if it's an economic issue, on a subsidized basis, delivered prepared, and make it easy for a family. You can set some modeling that eventually over time they may want to assume themselves as supply chains for more wholesome foods become available to them.
So a couple more minutes. Questions on bariatric surgery. Can you speak to why bariatric surgery patients have improved blood glucose post-surgery? The improvement occurs before subsequent weight loss. And do you think a year of preparation for psychological assessment is too large a barrier to get weight loss surgery, or do you believe that sets members up for success?
I can take a first stab at this. One of the things that we started looking when I was at the University of Minnesota is when we started doing this, the actual blood glucose levels would begin to fall right after surgery, before any weight loss occurred. And some of the animal experimentation that had gone on was to find out if you're able to exclude the duodenum as a result of surgery, redirect food away from the first part of the small intestine, that you don't set off the chain reaction of hormonal changes that typically occur with a meal. And many people still work with that as a basic point, but it's amazing that you actually start seeing the metabolic improvement long before you see weight loss.
Yeah, I still think there's a lot to be discovered in that area, and bariatric surgery is not my area of expertise, but I certainly engage in a lot of the specialists in the research side of that. And I mean, I think there's still a lot of crosstalk with the brain that we don't fully understand in that regulation as well. You are certainly not just rewiring or replumbing the gastrointestinal tract, but you are rewiring some of the neural circuitry feedback into the hindbrain, as well as the hormonal release that was talked about. So I think there's still a lot of avenues in there that need to be discovered for why there is that independent benefit on blood glucose prior to the weight loss. It's still a fascinating question.
Great. So I think the million-dollar question that a lot of folks are interested in hearing a response on is, what do you think the moonshot solution is here? We had some commentary. If carbs are a critical factor in creating this disease epidemic, could there be a moonshot to lower the amount of added sugar in food? But I think this would require policy, medical, food industry, and insurance efforts. So I think, Dr. Fitch, you spoke to, number one, this is a disease. So the moonshot is, let's all view this as a disease. And I think, we can go from there. So I'd love to hear your thoughts.
I think it's important to recognize that it's just simply changing nutrition or changing behavior is not curing the disease in most people. And that's what I was trying to get across. And it's great to do that for various reasons. And to have people do that. To your point earlier, Chantel, about, a year of preparation for surgery. Thankfully, most people don't have to do a year, and the getting programs down now to 4 to 6 months. Some people do have to do 4 to 6 months. Again, is that really, to say you have to do something for 4 to 6 months that has a 10% chance of being successful? Is that really fair? When someone has access to something that's 70% successful, and why can't they just have that now? Right. And so I think, we have to start thinking about it, as we said earlier, and as Kevin mentioned. I mean, we have all these, every day there's a new company such as Virta coming forth with technologies to be able to help us live better lives. Livongo, you name, the Onduo. I mean, there's all of these companies helping us. How can we really get that into the care system so that people have access to that, and even access to, as Dr. Magliari mentioned, food being, medically tailored meals being delivered, and access to this treatment is really what's key, and access to medications that really work. I mean, that's a big deal when only 30% of our country has access, because Medicare doesn't cover anti-obesity therapy, and most Medicaids do not cover anti-obesity therapy. And so making patients pay for this out of pocket to get access to these treatments, I think, is our biggest roadblock today.
One more time on mute.
God. Listen, as you start looking at this thing, I agree with everything that Dr. Fitch said, but I go a little further in realizing that you have to realize that the etiology of this problem is in part biological and in part social. I think it's one of the reasons, likewise, why Virta works, because there's a longitudinal relationship with individuals. And by having that longitudinal relationships, you can deal with both, make sure we're on the right protocols, titrated to the right levels, but at the same time, making sure you're mitigating the risk that life circumstances aren't going to interrupt that adherence to the plan.
Yeah, and just, I can promise you that my colleagues in industry, not just within Novo, but in the other leading companies in this area, you will see better and better pharmacological tools being developed. There's just no doubt about that. Eli Lilly has some amazing stuff coming out. Amgen does, Regeneron, all of the companies. There's a lot more attention. So the pharmacological tools will be there, but it's the healthcare engagement and access that are still going to be the limiting factor. And it's that ongoing engagement and personal or precision medicine that I think will be the key for the future of that. And not all the tools are in place for that right now. And I think that's where some effort needs to be put for the next moonshot. The pharmacological tools will come, but the other pieces still need to be worked out.
Any other closing thoughts?
Let me just say that the reason moonshots work is that somebody decides that they're going to have an audacious goal. They put together a plan, they align all the resources, and they do this in a multi-sectorial way. This is not something that's going to just be the solution from the health system. We're going to have the private sector involved. Business is going to have to be involved. And, this is a federal, state, local partnership with our communities to make this happen.
Well, I think this goes without saying that this was a pleasure to moderate this session today with this panel. We appreciate everyone's time. For the almost 500 people that dialed in, thank you. Thank you for the questions. Unfortunately, we didn't get to all of them, but I hope that you got as much out of this as we did. Appreciate everyone's time today, and I hope you have a great rest of your day.